I hope everybody has had a very good week. I want to speak a little bit today about the biventricular conversion after single ventricle palliation and the process of staged ventricular recruitment. I have no disclosures with regard to this particular presentation. The borderline left heart is a very interesting enigma because the definition of the borderline left heart requires very careful consideration before we can talk about biventricular conversion. It's clear that in some patients who have mildly small left heart structures, we don't even think twice about saying that this patient should have a biventricular repair. In fact, we don't even call it a biventricular repair, right? We say, okay, let's just repair the coarctation, let's repair the aortic valve. And the word biventricular repair does not even come into consideration. On the other hand, patients who have extremely small left heart structures, atresia of the AV valves, severe ventricular dysfunction, or multiple complex lesions, again, the same thing. We don't even think about, is this a single ventricle, or is this a biventricle, or is this in the middle? We just do single ventricle palliation without any discussion. It's really then for this middle ground of patients in whom there is moderate hypoplasia of the left heart structures, perhaps some ventricular dysfunction, perhaps valvular abnormalities or pathway considerations, such as the upstairs-downstairs ventricles, complex transpositions, in whom we start to ask the question, okay, what is the probability of a successful biventricular repair versus the probability of a successful single ventricle outcome? And we try to weigh those risks against each other in making very careful decision-making. There are a number of diagnoses for which this consideration of the borderline left heart comes into play. And here is a list of several of them. I won't have the time to go through all of these in detail, so I want to focus instead very specifically on one group of patients with hypoplastic left heart syndrome, Schoen's complex, and the variants of hypoplastic syndrome. That is, patients do not have a ventricular septal defect or AV canal defect. They have intact ventricular septum and have left heart hypoplasia. And I'm going to illustrate how we have thought about this patient population, understanding that the same principles apply to other disease complexes as well. The traditional paradigm is we see a neonate or an infant with a borderline left heart, and we at this point are forced to make a decision. Do we do a single ventricle palliation and go to a Fontan, or do we do a biventricular repair as a neonate or infant? But what I want to introduce and describe is a slightly modified process in which we can think about doing initial single ventricle palliation, but then rather than going to the Fontan procedure, consider ways to recruit the left ventricle so that in some patients, perhaps, if they have a good response, we can consider a biventricular repair. So I want to describe how we do this for the patients with the hypoplastic left heart. So here is a patient that may be very familiar to many of you, and that is a neonate with critical aortic stenosis and a left ventricle that is not functioning well in the setting of a very tight aortic valve. There is a dilated and dysfunctional left ventricle. This patient population, our first step is to say, well, maybe the afterload on this ventricle is what's leading to the left ventricular dysfunction. Let's try and relieve that obstruction. And so our first maneuver is to perform a balloon dilation of the aortic valve. But you do that and you find that still the left ventricle has not recovered and the child is dependent on prostaglandins. And the question comes up, what do we do here? Do we say, okay, let's go down the stage 1 palliation and have this patient be a single ventricle for the rest of their life? Or do we try to do a biventricular repair, which will be very high risk in this patient given the left ventricular dysfunction, with the hopes that maybe the left ventricle will improve or be adequate to survive the recovery period. So what are the tools that we use to make these types of decisions? There have been a number of analyses that have been performed based upon retrospective series. And these are all very nice. They are helpful, but unfortunately, none of these are 100%. The predictive capability of this type of these types of tools are limited, and so we use them, but not really to make a final decision. Many of these tools bring into consideration the morphology and function of the neonatal left ventricle. And so we can look at parameters of left ventricular function, volume, size, presence of endocardial fibroelastosis, systolic function. We can look at the valvular structures and make some assessments of what all of the left heart structures are going to look like if we were to achieve a biventricular repair. Sometimes we look at flow patterns and physiology. How much is the left ventricle contributing in the neonate? If you have antegrade flow in the aortic arch, that suggests that the left ventricle is contributing more than what the right ventricle is contributing, and perhaps this left ventricle can cut it. On the other hand, if you have retrograde flow, that may be a concern. You want to look at the other anatomy, the pulmonary veins. Are there other genetic abnormalities? Is this patient going to do well with the single ventricle palliation, or do you have risk factors for single ventricle that make you want to pursue this? In Boston, we tend to use the following parameters. Is the left ventricle apex forming? Is there endocardial fibroelastosis? And what is the flow pattern in the aortic arch to give us a physiologic sense of what the left ventricle is able to do? And based upon these parameters, we will then make that initial decision making in the neonate. It's not 100%, but this is our current algorithm. So if we have a neonate on prostaglandins, who by echocardiogram has a left ventricle that is less than 2/3 apex forming, and retrograde flow in the arch, and presence of EFE, frequently these go together. In that patient population, very clear. We just do an initial stage 1 palliation, whether that be a traditional, a hybrid, or some form of stage 1 palliation. In this patient, we have to think about, do we do an atrial septectomy or septostomy, or do we leave the atrial septum mildly restricted? On the other hand, if the left ventricle is apex forming and there's antegrade flow in the aortic arch, and at least as best as we can tell by echocardiogram, there's not endocardial fibroelastosis, then in this patient, we will pursue a biventricular repair, which may entail opening the aortic valve, performing arch repair, and perhaps a limited amount of work on the mitral valve in the patient who has abnormal mitral valve apparatus. Then we watch very carefully early on, and if there are signs of left atrial hypertension, we would much rather very quickly convert into a stage 1 palliation rather than persist in the biventricular strategy with pulmonary hypertension and other problems that can arise as a result. The group in Gießen has shown that in a set of patients in whom they perform the hybrid stage 1 palliation, pulmonary artery bands, and a ductal stent, in several many of the patients, in fact, there is growth of the left heart structures, including left ventricle, aortic, and mitral valves. And in many of these patients, they're able to achieve a biventricular conversion after several months to years of having this type of circulation. And so based upon that, we have also thought that in patients who are very close to being biventricular repair, perhaps we can take a similar approach. We have recently started to utilize more frequently total transcatheter stage 1 procedure. This is an example of a patient that we treated last year, a neonate with a hypoplastic left heart with a left heart Z-scores that were small. There was some aortic valve stenosis, but the aortic valve Z-score is around a -3. Left ventricle was not apex forming clearly, but there was some flow through this left heart. And we have not started to use MRI in the neonates, but the group in Toronto has utilized MRI very frequently. And I personally think that MRI in a neonate, if it's feasible, will be another important adjunct to helping us with this type of patient. But in this patient, we did a total transcatheter stage 1 procedure in which we placed flow restrictors into both pulmonary arteries and then a ductal stent. And management of the atrial septal defect in this patient, rather than performing a balloon septostomy and widely opening the atrial septum, we left the atrial septum mildly restrictive, and hopefully this would then allow flow into the small left ventricle. This is the very same patient now, 4 months later, believe it or not, and the left ventricle had grown significantly as a result of this procedure. And we are now continuing to watch and see how much growth we get. At some point, the growth will plateau, and at that point, we will proceed with the biventricular conversion. Now, this patient did not have endocardial fibrinolysis by echocardiogram. At least you can see here maybe some mild amount of endocardial fibrinolysis near the papillary muscle, but the rest of the left ventricle did not seem to have endocardial fibrinolysis. So we have some hope that this left ventricle will have growth potential. And so when we have done this total transcatheter stage 1 procedure in about 6 or 7 patients in the past few years who have left ventricular dimensions that are considered to be appropriate, and particularly in patients who do not have endocardial fibrinolysis. Okay, so once we have assessed that this patient is candidate for stage 1 or biventricular repair, the question is, what about those in-between anatomy? And for the patients with the in-between anatomy, we have a very low threshold for going to the initial stage 1 palliation, knowing that we can always reverse and go back to a biventricular circulation at a later point in time. So how do we then make the decision about when to do the biventricular conversion after we have done this initial palliation? Well, to better understand this, we need to fast forward a little bit to understand what are the risk factors for outcomes after biventricular conversion. So the next series of slides, I'm going to move ahead and say, well, who are the successful patients? Well, let's think of some of the obvious parameters that we would consider. The left ventricle end diastolic volume, we all know, is likely a contributing factor. And this is a old study from 2014 that assessed our experience to that point. And in this study, end diastolic volume contributes to success after a biventricular conversion. And you can see that there are several discriminators here. A left ventricular size of greater than or less than 30 had a very good discrimination. 45 was also good. So it's not an absolute number, but based upon this, we have said 30 is our sort of threshold number. Well, what about the end diastolic pressure? We know that the diastolic function of the left ventricle is very important. And again, another analysis that we did on 50 biventricular conversion patients showed that indeed end diastolic pressure prior to a biventricular conversion is associated with the outcomes. And the inflection point was somewhere around 13 millimeters of mercury. So if we have a patient who has end diastolic pressure greater than 13, we pause and think, okay, is this the right thing to do? If it's less than 13, then we have no concerns or less concerns from that standpoint. Finally, I mentioned earlier about endocardial fibrolastosis, and this is only present in the patients who have the hypoplastic left heart syndrome variants, shown syndrome. It's not present in many of the other disease types. And so in this study, we found that it was very clearly associated. The presence of endocardial fibrolastosis was clearly associated with a worse outcome. And this is a composite endpoint that we looked at in this patient. So transplant-free survival, as well as takedown to single ventricle palliation, pulmonary hypertension or left atrial hypertension, so hemodynamic failure per se. So based upon these, we then will come back at the time of the bidirectional Glenn at 4 to 6 months and perform MRI and catheterization. If there is end diastolic volume greater than 30, end diastolic pressure less than 13, and no EFE, perform a biventricular conversion. And that happens in a subset of our patients. If, on the other hand, the anatomy is still not favorable, that is, we have volumes that are less than 30, end diastolic pressure greater than 15, and EFE, then in that patient population, we will perform a staged left ventricular recruitment. And what this procedure is essentially keeping the Damas-Castansel anastomosis. We go into the left ventricle at the time of the Glenn, remove endocardial fibrolastosis, perform mitral valve and aortic valve repairs, and then restrict the atrial septum with a patch and a small hole to force the blood flow into the left ventricle to promote growth of the left ventricle. Typically, in addition to doing the Glenn, we will add an additional source of pulmonary blood flow, either by maintaining the right ventricle to pulmonary artery conduit or the aortopulmonary shunt. This endocardial fibrolastosis is, as many of you know, is a very thick and cartilaginous material. It can be laborious to remove through the mitral valve, but our approach is typically through the mitral valve to visualize this. We try to take it out in a single piece, so trying to use the handle and get into the correct plane and take it all the way down to the apex. Very important that you get the apex resected, because if you don't, then that left ventricle will not elongate and the apex will not improve in size. One thing that we're also doing at the time of EFE resection is actually remove just a little sliver of muscle, because as I will show in future slides, we frequently will find that this EFE material extends further into the ventricular myocardium. So what is this EFE and what are the characteristics? So here you can see a histologic slide that shows the endocardial fibrolastosis, and it is a very thick layer of elastin-heavy material that really has a distinct border with the muscle. But as you can see here, there are many extensions of the EFE into the muscle itself. And so if all you do is to remove that layer but not get a little bit into the muscle, then you'll have recurrence of the EFE. And in fact, this into the muscle may cause some of the fibrosis that we see in this patient population. In our laboratory, Dr. Ingeborg Fries has studied endocardial fibrinoelastosis to understand the mechanisms of development. And what she has found is that it appears that some of the cells that are labeled as endocardial fibrinoelastosis, when stained simultaneously for markers of mesenchymal cells, so interstitial cells or medial cells, they also co-stain with endothelial cells. And so her hypothesis is that there is what is known as endothelial to mesenchymal transformation, where some of the endothelial cells get transformed into fibroblastic type cells that stain with mesenchymal markers. And this transformation is the reason why you see some of the extension of these from the endocardium into the muscle itself, and can go quite deep in some of these patients. So at the time of EFE resection, we're taking some muscle, and then we analyze that in the laboratory to see how deep is the extension, to try to come up with some grading phenomenon to understand the extent of EFE and to better then predict and prognosticate how these patients are going to do. Ultimately, Dr. Fries has been working on potential treatments to prevent the extension and recurrence of EFE, and she's found that there appears to be some interaction with the TGF-beta pathway, and so perhaps inhibition of the TGF-beta pathway may be an option for treatment of EFE in these patients. So let's say we have done the staged left ventricular recruitment with removal of the EFE. We have restricted the atrial septum, and we now are observing this patient. So this is an example of an MRI that shows what can happen with this type of process. And here we see clearly there is increase in the size of the ventricle, and there's maintenance of function. And if we do MRI flow measurements, we find that the left ventricle is contributing much more to the cardiac output in this population. So you can assess the parameters. We can then do a cardiac catheterization, see what is the end diastolic pressure. We know that with this, there can be a significant growth of the left ventricle compared to if you just do the traditional stage 1 palliation. So here I'm looking at the left ventricle end diastolic volume. The open circles are patients who have had this left ventricular recruitment surgery compared to a similar cohort of patients that just had traditional stage 1 palliation in the black dots. And clearly there is a trend towards improvement. But usually that happens after the time of the bidirectional Glenn. In this phase between stage 1 and the Glenn, we typically do an atrial septectomy. And so without the nidus for growth, without the nidus for flow into the left ventricle will not grow. However, if at the time of the Glenn, we then perform atrial restriction, we can see the trend towards a growth. So the time frame is typically between the Glenn and 2 years of age that we see this growth. So at 4 to 6 months of age, we come back, we do the EFE resection. Now we repeat the MRI and cardiac catheterization at 1 year. And again, we use the same criteria. If the end diastolic volume and pressure are appropriate, then we go down the biventricular conversion pathway. If the parameters are not favorable, then we have to think about whether to just go to a Fontan and say that we've tried to recruit the left ventricle. We may try a second time to do another staged recruitment surgery, so more EFE resection, aortic and mitral valve work. And we'll do this if we notice that, oh, this mitral valve was really stenotic and that's why it didn't grow. Let's go and do more repair now that the child is bigger. Or if the EFE has recurred, then maybe a repeat staged ventricular recruitment will be valuable. And then we come back again at another year and repeat this process. At some point, we say, okay, this left ventricle is not going to respond and can have a Fontan procedure. However, there are some patients who have the risk factors for Fontan And we were stuck with the dilemma: how do you manage those patients who have, a left ventricle that's present but not adequate? You don't want to do the Fontan, but they cannot have a biventricular conversion. So what do you do in that situation? So in the past few years, we have adopted the reverse double switch operation for these types of patients who do not have adequate response. And this is just the same as a double switch, except you are now making the right ventricle systemic and you're using the left ventricle as a subpulmonary ventricle. This procedure is obviously done commonly for corrected transposition of the great arteries. And in that situation, it's being used for the opposite purpose. So this requires an arterial switch operation, an atrial switch operation. And depending upon the size and the parameters of the left ventricle, we can add a bidirectional blend to unload the left ventricle. So this option is a good option for patients in whom you do not want to do the Fontan, in a patient that has good right ventricle and tricuspid valve function. We have now done the reverse double switch operation in approximately 10 patients, and there was no mortality. And at short-term follow-up, 2 or 3 years is the furthest out we have our patients. They have had good function, both of the ventricle as well as symptomatic. And when we have done cardiac catheterization in some of these patients, we find that their IVC pressure is low, even though this is a suboptimal left ventricle that is now pumping for IVC blood flow. So we think the unloading of that left ventricle does something to allow better compliance of the small ventricle. So at this point, this is kind of where we have landed in terms of our algorithm for treatment of these patients. So if you have a patient that has had a staged ventricular recruitment, they come back at an MRI at 1 year of age. We then look at the end diastolic volume, end diastolic pressure, and we will make a determination as to whether they're suitable for a biventricular conversion. I will point out that these parameters are never 100%. I sometimes use 15, I sometimes use 13 in practice because it's not a fixed number. There's clearly a spectrum, and so each of these decisions are made very carefully based upon assessment of that patient's risk factors for both the biventricular conversion as well as understanding what their risk factors are for single ventricle palliation. And these discussions frequently require several visits. We have a multidisciplinary group, including imaging team, cardiac catheterization team, and then the families. And we try as much as possible to give an idea of what the risks are for that child to go down the biventricular circulation. It's hard to put exact numbers, but we can try to say, well, these are clearly some risk factors for that. And then if the left ventricle has some response but is not adequate for a biventricular conversion, then more frequently now, we are performing the reverse double switch operation as an option to achieve either a biventricular or a 1.5 ventricle circulation. And the goal really being to avoid complications of the Fontan, because we know that 1.5 patients do just as well as biventricular repair patients for the most part. It's really the elevated pressures in the IVC that that create the problem. And so if we can avoid that last step of the Fontan by maintaining low IVC pressures, then perhaps we can avoid the liver injury and other end organ injury complications of the Fontan that we typically see. And as I said earlier, with the reverse double switch, now it seems that the inferior vena cava pressures are frequently in the normal range. And importantly, there's a pulsatile nature to it. So it's not passive flow. And you can see the more normal hepatic flow profile. And so we think that this is a good option for some of these patients. I want to leave some time for discussion. So I'll conclude with this by saying that the patients with the borderline left ventricle, and here we're talking only about hypoplastic left heart syndrome and the variants, but this can also include unbalanced AV canal, complex transposition, now doubling the ventricles. For patients who are not candidates for immediate biventricular repair, perform a single ventricle palliation, but consider a staged approach and consider trying to volume load the left ventricle. In other words, don't give up on the left ventricle. And use parameters that I think are going to be based upon diastolic volume and diastolic pressure and other biological factors, which we will continue to develop over time, to really select the right patient for the right approach. We know that at this time, single treatment modality for everybody does not make sense, whether it be everybody gets a stage 1 or everybody gets a biventricular conversion. That's too much of a hammer approach. We need a more precision medicine type of approach where we can look at the behavior of that particular patient. I might envision even bringing in genetics, proteomics, and other types of biological analyses as well into this picture. But to try to find those predictive factors and build an algorithm that includes not only a single ventricle palliation towards a Fontan, full biventricular conversion with the systemic left ventricle, but also considers the reverse double switch operation with a systemic right ventricle. And I hope this was a stimulating talk, and I hope to have some good discussion to talk further about the borderline left ventricle. Thank you very much again for the invitation, and I very much would love to come visit Italy. It's my favorite country, and I look forward to seeing all of you very soon.
Thanks, Ram. Thanks for this impressive lecture. So I have to start with a few questions. Just from a technical point of view, when you decide to restrict the atrial septum during the normal stage 1, how big is the hole you put on a patch? 4, 5?
Good question, Vlad. Until now, for the most part, if we are doing a traditional surgical Norwood procedure, our thought has been to just remove the atrial septum completely, because we don't want that patient to struggle at all from the recovery from the Norwood. Having said that, now with the total transcatheter stage 1 palliation, or with the hybrid type of approach, we don't open the atrial septum widely. We leave a little bit of restriction. And In that situation, we use the gradient across the atrial septum to help us decide which way to go. Population after a neonate who has had a hybrid stage 1, I think an acceptable gradient across the atrial septum is somewhere around 4 to 7. If you have a gradient that is much higher than 7 or higher than 7, then we will consider going back and then stenting the atrial septum or opening it a little bit more to bring that down until the next stage. At the time of the bidirectional Glenn, when we are performing a more formal LV recruitment and restricting the atrial septum at that time. So at the time of staged ventricular recruitment, we use a patch of either autologous or bovine pericardium and put a 4 millimeter punch in the middle of it. And we do this because we found that when we try to restrict the atrial septum with just sutures and approximating that the size of the hole is never what you think it is going to be. Whereas if you use a patch with a hole punched in the middle of it, it's much more predictable, and you can do more with it in the cath lab if they need to either enlarge it or close it.
Okay. So regarding the EFE, even though it's quite difficult in a neonate, are you still trying to resect EFE during the normal stage 1, or you demand to at the time of the Glenn?
Right. There was a period of time where we were aggressively resecting EFE even in the neonate, but what we found is that it frequently was incomplete and very difficult to do, especially if you have small mitral valve structures. So in the most recent series, we've not done EFE resection at the stage 1 palliation. But again, it's a little bit dependent upon what the size of the mitral valve is. So if the mitral valve is adequate size and the left ventricle is small for whatever reason, then that patient you may consider some limited EFE resection.
And during the Glenn, if you attempt an LV recruitment, do you prefer personally to put a BD shunt or to upgrade the RV to PA conduit? Just from a technical point of view.
Yes. I tend to keep the right ventricle to pulmonary artery conduit if it appears that it is giving enough blood flow. So before we go to the recruitment procedure, we do the MRI and the catheterization, and we can calculate the QP to QS. So we know how much flow is going through that RV to PA conduit. If it is somewhere around 0.6 to 0.8, then we will leave it and just add the Glenn. The technical point there, however, is that we put a membrane inside the pulmonary artery to separate the Glenn from the RV to PA conduit so that you don't get retrograde flow. For some time, we would just do the Glenn and keep the PA open, and we had a very high incidence of retrograde flow in the Glenn and development of veno-venous collaterals. That has almost completely disappeared now with banding between the conduit or the shunt and the Glenn. We will do an aortopulmonary shunt if sometimes, the RV to PA conduit is narrowed more significantly and has some proximal obstruction or is tenting up the pulmonary arteries. In that case, we take away the RV to PA conduit and then add in the aortopulmonary shunt.
Okay, just one other quick question. After you do a biventricular repair, you always put an LA line maybe for the postoperative monitoring, right? Which is your threshold of pressure you tolerate, 20.
Right. No, it's a very good question. So, it's tough to know what to do with the numbers because many of these patients will have a low number while they're sedated and paralyzed and still. As soon as you wake them up, they'll have increase in the LA pressure that can go into the 20s. with management on the ventilator. We haven't found that those spikes with finding the ventilator while waking up, etc., correlate necessarily with the long-term outcomes. So we will look. Patient is sedated, and then if we're happy with the number, we remove the LA line, so we don't look at it anymore. But if the LA pressure is elevated even in a sedated and paralyzed patient, then we're going to assess that, start with echo, maybe repeat the catheterization, understand why this is happening, and then we may have to make a decision to convert to a stage 1.
Okay. One last question, then I give space to the audience. Do you still believe in fetal maneuvers to maybe aortic balloon valvuloplasty or other to decrease the possibility of developing EFE maybe?
Yes, I think it's clearly there's a role for fetal intervention on the aortic valve or the atrial septum. I think probably the intact atrial septum population makes more sense because they come out extremely sick, and a fetal intervention there has really limited the number of exit ECMO and crash to the cath labs that we have had to perform. The balloon dilation of the aortic valve, I think, may improve the capability of the left ventricle to be ready for a biventricular circulation. But it's very hard to prove that point, because we don't have randomized data, and all the retrospective data are going to be contaminated. So it's been very difficult to know what the benefit of that procedure really is. But we're still doing it for the appropriate patients.
Thank you so much. I don't know if Lisa or other surgeon or the cardiologist has some questions for Dr. Emani.
Thank you very much, Dr. Emani. It was great. I guess there is here at least much more and more interest in the biventricular convention to kind of also avoid transplantation in the bad Fontan patients. We had recently bad outcomes in good Fontan candidates for transplantation, and also with good, good donor heart. So we were now discussing this strategy. But one question we received was if there was any center that have estimated how many Fontans can be reconverted. So I don't know if you have an idea. I know that in Boston you receive patients that undergoing a Fontan operation, then they go back to their country. So maybe it's difficult for you to have a percentage, but maybe, I don't know, because it could be a very good option for us. As Vladimiro mentioned to you at the beginning, we recently converted a Fontan patient, just also to avoid the transplantation.
Yes, very, very good question, Alicia. And as you very well know, we have done Fontan conversion to a biventricular circulation in a number of patients with various different diagnoses, and it certainly is possible. What we found from this study was that if you're going to do a biventricular conversion in a Fontan patient, it's better to do it before they have complications of the Fontan. So patients who already have advanced PLE, advanced hepatic fibrosis, and other sequelae of the Fontan, well, if you do the conversion after they have that, many of those comorbidities still persist and will impact the recovery after the biventricular conversion. So the mortality is higher in those patients. So if you are going to do a biventricular conversion after Fontan, our suggestion is you do it the day before they develop the PLE. And obviously, that's very difficult to predict that. So this is the conundrum. Do you take a healthy Fontan patient who has anatomy that is amenable to biventricular conversion, and you do an elective biventricular conversion strategy that can have some risks associated with it? Or do you wait for them to develop the PLE and then do the conversion? And our center is very aggressive. If we see a patient who's a Fontan that has two decent ventricles, we will ask the question and bring up the options to the family. But it's still very early to know what is the right selection criteria for doing that. And so this is definitely an opportunity for really a multi-institutional collaboration to solve this question.
Yeah, I guess that there were some thought in the past of having a Fontan with two ventricles, maybe it's a better Fontan, but maybe we need to take account of these patients to reconvert them, maybe.
Yes, absolutely. And I think, it is, our minds as humans, our minds are always very one track. Once we do the single ventricle palliation, we just we see the two ventricles, but we still don't, we don't think about that biventricular repair. I think as a community, we have to train ourselves maybe to think hard about this patient population. Not only surgeons, but imaging folks, cardiologists, catheterization, anybody who's seeing these patients should always ask the question. It may not be the right thing for that patient, but at least the discussion should be there.
Fantastic. Any other questions?
I'm here with two of our pediatric interventional cardiologists. They were curious about the strategy for hybrid repair. Maybe Domenico or Piaggio can.
Yeah, just if there is any, I think you have a specific protocol, and do you bend the pulmonary arteries in any case with the microvascular plugs, or you just, decide in each case? And also, what's the intention? How do they open the interatrial septum? Do they put any device or just do Rashkin procedure or what?
Yes, thank you for that question. This is an evolving process. And really in the past 2 years, we have almost shifted completely from doing traditional stage 1, surgical stage 1 to the total transcatheter stage 1 procedure. And there was a learning curve there. So we do use the microvascular plugs, the occluder devices, but they're modified. So the plugs have to be incised. And there was a learning curve there for how big to make that hole. Initially, we were using a very fine blade and just making an incision in it. But what we found is the very thin PTFE material expands and propagates. So the hole becomes big. And so some of these patients had, suddenly they would have overcirculation. What we have gone to doing now is using an electrocautery. So using a burn device. So burning a hole, it creates a singe around the end of the PTFE, and that prevents it from expanding. So the eye cautery, almost burning a very tiny hole in the material. Now that has been more stable in terms of creating a fixed size that will not grow and get bigger over time. So that was one learning point. It took us some time to finalize that, and thanks to your own Nicola Maschero for being really in the center of this. I think as we have done some of these, we found that they're actually very easy to remove, and I personally find them better than external pulmonary artery banding, because when you do external pulmonary artery banding, you distort the pulmonary arteries, and especially if you have to go to the single ventricle palliation, no matter how much you try to enlarge it, it is always a problem with the PAs. So for that reason, I like the intravascular plugs, because they're actually relatively easy to remove, even when you come back several months later, and they arteries. You have to be a little bit careful in the placement that you don't jail the upper lobes. We have seen that in some situations. So you just have to be careful about not getting too deep into there. They have to stay a little bit into the pulmonary artery.
Other questions?
Thank you.
I think Biagio had another question on the algorithm. No.
No, my question is about the creation of calibrated atrial septal defect. If you have experience with the atrial flow regulator device, if yes, in which phase? We implanted the device hybrid approach in a small baby, but I would like to know your experience with this device, percutaneous and hybrid approach, if any.
Right. Yes, we've, speaking a little bit about the atrial septum, and that I think I did not answer previously also. We would, we prefer to leave a patch with a hole in it that we can then modify. And frequently, if you just wait for some time, there will be narrowing on the inside of that small hole over time. So we're rarely narrowing the hole. If anything, the only thing that may be necessary is to expand the hole. And when we go to expand the hole, we prefer to use a stent so that we don't open it widely at the time of catheterization. So we'll prefer to put a small stent and dial it to the exact diameter that we want. And we feel that that is a better approach. We haven't used other devices in the atrial septum for this patient.